Hi everyone, welcome to researchmd.com. A great presentation today. We're going to teach you all about venous ulcers today, okay? Again, my name is Pramil, Cheriyath, the Program Director, Internal Medicine Residency, Transitional Residency. I teach medical students and residents on a regular basis. Since we don't have much time, all our presentation are 9 minutes precise, all the facts you needed. Please make sure you watch it again and again so it just stays in your memory. Let's start it. What is venous ulcer? You got more venous insufficiency, right? They cause like pooling of the blood, and then shallow open lesions with irregular borders and weeping of the serous fluid, and usually like in the lower leg. And the most common is the lower extremity ulcer, okay? And that can persist for weeks and sometimes persist for years in a lot of people, and very complicated situation. Epidemiology, if you look at it, around 1% in the United States, 4% reported in the ones greater than 65. The older you get, like more chance, women more, and greater than 65 years old. What are the risk factors? One of the risk factors we have to worry about, like varicose veins and DVT. Prior surgery for like varicose veins, phlebitis, let's say, if you have heart surgery, they have taken the vein from your leg and did some surgery for the heart. That can also cause us families to venous disease, heart failure, obesity. Obesity is again a big reason for like venous insufficiency also. Immobility, prior leg injury, and you had surgery to that leg. Injection drug use is one of the other causes, and smoking can also contribute. So a large number of risk factors, right? And then what happens is like, the venous return to the heart is affected. There's like venous valve incompetence. So why is that? Because venous thrombosis is there, previous trauma, congenital defect, lack of venous pumping from inadequate calf muscle. Maybe the calf muscle is not working like to pump the blood back to the heart, okay? And then pathogenesis, if you look at, there is again the pooling of the blood. That's what happens in venous insufficiency. There is like inflammatory process. You got leukocyte activation, endothelial damage, platelet aggregation, intracellular edema, and all of this kind of lead to tissue damage, impaired healing, and all that. So if you get a nice picture over here and kind of tell us like what is the pathophysiology, what happens, you got varicose veins, ambulatory venous hypertension, and then you got venular and capillary dilatation, and decreased capillary perfusion pressure, decreased endothelial tissue, increased capillary permeability, and then you got white cell trapping, adhesion, activation, plugging of heterogeneity of perfusion results in hypoxia and activation, release of free radicals, proteolytic enzymes, cytokines, and chemotactic substance, and that kind of damage causing all this ulceration, delayed healing, okay? So what are the clinical findings? Mainly you can see the superficial ulcer with irregular arches, granulation tissue, serous exudate, eczematous changes, reddish-brown pigmentation. You got firm browny edema also, varicose eczema, like which is weeping, dry, or itchy, associated varicose veins. You got lipodermatosclerosis with thickening and fibrosis. Atrophic blanch, and you can also see the signs of the healed ulcers also. Extremities, ulcer frequently in the medial side of the ankle, okay? And the malodor, increased exudate may suggest an infection. So how do you diagnose this? Mainly the clinical diagnosis. You examine the patient, physical examination, right? And then make sure you always differentiate between venous ulcer and arterial ulcer. That's the most important thing, because the treatment is like very different for both of them. So always, if you want to do like an ankle brachial index to rule out arterial insufficiency is very, very important. So how do you manage the patient? You do compression therapy without dressing is the mainstay of management. Again, compression therapy, the mainstay. And then you can initiate the Breedman recommended because to reduce the bacterial burden and remove that necrotic tissues and all that, okay? So compression therapy, just kind of look at it, high compression. You got the multi-component bandaging recommended for routine treatment. I mean, if you look at the three graded, like a lower like 30 to 40 mm pressure, then 20 to 30 mm pressure, 18 to 22, and the 15 to 20 and the upper level, okay? And the below knee graduated compression recommended to reduce recurrence, and is associated with a reduced recurrent ulcerance also. Compression therapy, so that is the main management of this. And what are the other things? So you have to be careful about the dressing. So you can do simple non-adherent dressing is recommended. or you can do low adherent dressing. You can do silver impregnated dressing. You got foam wound dressing, and also you can do porcine, small intestine, submucosal dressing, and all of this can help with the the other thing is you do activity, always elevation of the leg above the level of heart for 30 minutes, 3 to 4 times daily. Supervised exercise to improve calf muscle function. Medication also have some role in it, like pentoxifillin has been studies have shown with associated with more healing used with the compression therapy. Aspirin is also recommended, and intravenous administration is iloprost also may be like beneficial. Those are the medications. So the topical medication like cardoximir iodine can improve the healing of the venous ulcers. You got lidocaine, prilocaine, 5% cream can decrease the pain and the ulcer debridement. You got keratinocyte therapy associated with improved healing. You got vegetal biomembrane, and then intramuscular medications like saldoxide, and also you can treat with the compression therapy. Okay. When you talk about surgery, also like superficial venous surgery, that can reduce the recurrence of the ulcer. You got subfacial endoscopic perforating vein surgery you can do. That's what they can do the superficial vein ligation. You got endovenous radiofrequency ablation also has a role. Bilayer artificial skin replacement can improve, and the skin grafts or artificial skin also be very helpful in these patients. So treatment setting, treatment when you look at the specialist versus traditional treatment centers. So if you go when somebody have like venous ulcer, like 69-74% improvement compared to traditional treatment centers. So make sure when you have like a chronic venous ulcer, send it to a specialist. So the complete healing is much better when it's been taken care of the specialist. And the management, there's a role for ultrasound therapy, electromagnetic therapy, topical negative pressure therapy, and hyperbaric oxygen therapy is also becoming common. And the complication, again, you have to rule out infection. That's the most complication you have to worry about. Osteomyelitis, common cell carcinoma also because of the venous ulcer, and contact dermatitis. So impact of leg ulcers on patient daily, like a lot of complications, right? Pain, immobility, sleep disturbances, activity limitation, frustration, reduced self-esteem also. So prevention, management, all the things we talk about, exercise, prevention, early diagnosis of DVT, venous surgery, compression therapy, and the secondary prevention of recurrence, use of compression therapy, medical compression stocking, and below knee graduated compression osteo. And these are the references, and thank you so much for watching. We'll be back with another presentation soon. Thank you.